with you.
Is that okay?
Hopefully,
You happy if I record, Trish?
absolutely fine. Yeah. Yeah. So, no, we thought we'd really talk about things pleural today, sort of to do with pneumothoraces and pleural effusions. And this is part of my favorite topics when we're using point of care lung and ultrasound in neonatal intensive care medicine. We'll go back to the basics. And I think even though this slide takes us back to 2012 with the international recommendations about the use of lung ultrasound, it gives a really nice, simple framework that you can apply clinically when you have an image and a baby before you and you're trying to answer that question, could there be air leak present? You really have to go sequentially here in your thinking of the presence or absence of lung sliding, presence or absence of B-lines, presence or absence of lung point, and so on. And I think it just reminds us just to do this methodically and stepwise, and you really don't sort of move forward until you can answer one or two of those questions. And it might be moving the probe to other areas, or it might be changing from 2D to M mode to help you answer that. But it's just nice to know you're not going to get your answer just with one simple question. So hopefully you'll recognize here that this is a midline longitudinal view. So the probe notches to the baby's head, and you can see some tissues here. You can see the sternum with the little ribs inside. And I think it highlights just some beautiful things here about ultrasound. You've got great definition of the thymus just here. Is that tissue and defined region that's sort of sliding and moving away. And as you come along here, this pleural line, I'm sure you will recognize here, there's a thin, white, defined pleural line that changes in nature as you're coming down the baby. And perhaps putting those sort of thoughts in your head of how you approach that description. Most would usually say, starting with the definition of the pleural line, is it well-defined, thin, regular, or is it more sort of coarse, irregular, or disrupted? Then talking about movement observed, and then talking about the dominant artifact profile that you can see. Is it really dominated by strong horizontal vertebral artifacts of A-lines? Or is it the ones coming from the pleural line as B-lines originating and sliding with movement? And I think those of you reading ahead will recognize here two really distinct patterns you're observing that are more reflective of normal lung sliding with presence of B-lines to a really sharply distinct change where this pleural line is no longer sliding, is crystal clear, really strong repeated A-lines throughout, and not even a whisper of a B-line, really suggestive of pneumothoraces in this area. So this is usually called the A prime profile, absence of pleural sliding, an A prime profile with absence of B-lines, and that special point there, lung point. What is lung point? It's really the physical limit of the pneumothoraces where the parietal and the visceral pleura have separated and coming back together. Matt and Mike are friends in the US. They did some amazing podcasts in the last decade or so. And again, just showing this in an adult version of a CT, just to help you visualize this cushion of air that's there, separating the parietal and visceral pleura. So another example here. So again, this is a standard right anterior longitudinal plane that you would have in the midclavicular line. So the probe notches up towards the baby's head. So you see here lovely chest wall tissues, ideally symmetrical appearance of each little rib shadow. And then again, think about the pleural line definition, even changing within one rib space. You know, there's no real other explanation for that in that area. You can see inferiorly, perhaps you've got solid organ coming in here for sure. And then this artifact dominating and wiping out normal structures. So here I would describe lung point within one intercostal space that you've identified a sharp transition in the quality of the pleural line, the nature and movement of this pleural line, the dominant artifact profile of these A-line presence or coalescent Bs, and nothing else gives you that image. There's other discussions about false lung point, and it gets really confusing, and double lung point that you might get in a transition of B-line coalescence that changes with gravity and fluid clearance as in TTN, but it's not as exciting as this. It's not a sharp and accurate transition. I like to think pneumothoraces is about standstill. So observing here, you can see how there is just static nature of this pleural line. It's thin, it's well defined. You can see the chest wall here. And what this is actually a baby with a little pigtail catheter. I want you to note this little part carefully here. You get a little bubble arising occasionally. This baby had pneumothoraces and actually had a catheter that was not functioning, probably blocked or kinked in some way, traversing the chest wall. And you're observing standstill. And I really want you to think why. You've got the chest wall there, the parietal pleura, but it's thin and defined, but there's no horizontal sliding at all. There's no movement at all. It's because you can't diagnose behind air. Really important now. The actual parietal pleura separated away with the visceral pleura acts like almost a reflective mirror. Okay, reflecting, refracting, those ultrasounds coming from the probe, going through the tissue, hitting that sudden change of interface of surface from tissue to air, bounce away, don't know how to get back to the probe. And you just get this repeated pattern of anything above that parietal pleura below, but absolutely no sliding. You need the contact of the two to produce sliding and the artifacts generated from it, particularly B-lines and lung pulse. Okay, learning to get your eyes in, tune in on this pleural line movement. So here I've got a baby, and if you start from the top coming down sequentially, you've got the chest wall tissues, you've got the beautiful little ribs in a cross section. Watch the tissues in between. You can see this heave, this vertical recession going on, and how different this is to the horizontal movement of the pleura, visceral on parietal, and that movement as a constant scattering motion of breathing. So really getting your eye in on what pleural movement is and quality, and how it differs from that heave and recession that you get in babies. It's almost like three movements in one going on. And if you can, try and breathe with the baby if it helps you understand that. But you're just learning to separate movement at different layers. So this is something that's exemplified when we use M mode. Just remember M mode of movement across the line with time as you go forward. And some people, way more clever than I, have come up with the terminology here, Merlin space. So really starting at that pleural line, coming down by the borders of the acoustic rib shadows, basically the bit of artifact area. Remember, you're not seeing lungs. You're looking at artifacts generated at the lung surface. So they turn this Merlin space, but it's just so you hone in and tune in. What's happening here? Is there sliding? Is there B-lines presence? What's going on? Above this and superficial to the parietal pleura, you have Keys space. So really you're interested in what's happening above and below that pleural line. Okay, just some terminology. You might hear people talk about it. And what you're really interested in is how they differ as you come down across this line. As you go with depth, coming through those tissues and hitting that lung interface, that surface, how does this pattern change of movement of structures with time? So in a normal lung baby that's healthy, you're going to observe your A-line profile. Yep. But on M mode, you're going to see the seashore sign. So it's starting at the top because the chest wall isn't moving that much. There's very limited movement and it appears more like a bar going across. So that's your waves. You hit that bright transition of the pleura in contact together, sliding beautifully, constant scattering reflector, and that's your grains of sand. So here looking at the Keys and Merlin space, it's a different pattern as you cross that pleura. It's a little more obvious when you have more B lines around. So A lines can be a little tricky in really hyperinflated lung. Now, if you come to one with more of a coalescent B profile, there's just a lot more contrast, a lot more sand involved, and you can pick it instantly. Yep, there's a pleural line, those are spaces. Yes, the pattern changes as you cross that line, the pleural line with time. Okay, looking at this transverse, this is a right anterior inferior transverse. So across the chest wall, you've got the probe in a horizontal plane, not ideally to the patient's right. Hopefully you're observing here, you've got some chest wall structures, some ribs kind of flicking in and out of plane, bright defined pleural line, it's pencil thin there. Okay, you might observe a mirror-like artifact. You can see the rib up here above the pleural line and a suggestion of a rib coming below. Okay, but this thinly defined pleural line and this almost bounce-like quality, geometric sort of shape that you get with air leak, very strong A lines that don't really fade so quickly as you go through with depth. And I get this sort of feeling of bounce here and recession. It's not that beautiful horizontal movement. It's just this heaving movement up and down. And things like that can point way more towards air leak. Using here M mode here gives you that barcode or stratosphere sign. So you're crossing that line. And remember, everything is reflected at that parietal pleural surface. So it's just a repetition. There should be no change as you come down from inferior to further deeper in the chest. It's just the same all the way down, hence barcode. All right, but babies don't sit still. An adult, easy, you can get them to hold their breath if they're compliant. But a baby with a severe pneumothorax that's severely compromised is going to be dyspneic. Chest's going to be heaving away, banging away in front of you. And this causes what they call parasites, the Avicenna sign. So the chest wall isn't as still as you'd like it to be. So you get this sort of sand appearing above the pleural line. But it's important, does it change in nature and quality as you cross that pleural line? Because if it's mirror image of that above, highly suggestive of air leak, you can't diagnose behind air. Okay, if it changes in quality and pattern because of contact and movement, it can really help you define you. And when you do this in reality, when you press your M mode and it's sampling it, you often get a really nice grainy, weird, soft gray 2D picture that you can actually see the contrast of pleural sliding a little clearer sometimes. So that in alone can help ask me that question. Is there presence or absence of pleural sliding? Okay, what about all these artifacts on other types? You can have babies that are spontaneously breathing, CPAP support, you name it, what type of ventilator. So a couple of examples to show you. The physics is exactly the same. We have babies extremely preterm nursed on the high frequency jet ventilator here or oscillation. The physics is the same, guys. You're going to see here. So observing tiny little one. This is right anterior longitudinal, so mid-clavicular line. You can see the little ribs in cross section. Note the change of the quality of the pleural line here. Okay, superior region, you've got fuzzy, coarse, bright, irregular, huge dominance of B-line coalescence. And as you come down inferiorly in that chest, sort of further down the sternum, you start to hopefully observe a change in that quality of pleural line, maybe mirror image artifact, stronger A-line profile, and lack and absence of B lines. And that transition right there, you should be observing is lung point. Qualifying that on M mode, just to show you, look at the nature of the 75 millimeters per second. That's the jet ventilator artifact kicking in. So I know that's working, but I'm interested in the pattern, the observation. Does it change top to bottom with time? And you can see in the sandy gray region, it's really quite sandy, okay? And then if I go in the area of suspicion, completely different. So let me go back. You get a recognition of what's normal for this baby with this B-line coalescence and not a lot of movement of the chest wall, but really artifact dominated from the jet, and then flicking to the area of interest, completely different. Okay, without a question of a doubt, I'm getting scrubbed and ready. I know this baby's 500 grams, starting to be compromised. I think what we've done here is diagnose with absence of pleural sliding, thin defined pleural line, lung point, and the change in presence, absence of B-line artifacts, and very strong clinical suspicion. Okay, again here to show you, with adults, they really like to show your M mode in the cursor region where it is that transition. So you're coming in and out of that normal movement. And you can see here, I've plopped the cursor here and I've sort of fast forwarded forward. You've got what you've observed before, the stratosphere appearance that's coming into play when you're in that area of air leak. Okay, and again, another region here. This is more of a lateral appearance. I know that because of the shape of the ribs and the sort of shape that you have, a nice 3 rib space, and then solid organs coming down inferiorly. But again, in that area where it's B lines, it's easy. Yeah, it's such a sharp contrast. Come to A lines, totally different. And that's just moving 1 rib space down now. There shouldn't be an explanation for that. Right, so really easy, yeah? In reality, no, it's not. And I want you to have a healthy respect that sometimes this isn't as pure as you'd like it to be. Of course, when baby's incredibly sick, it is easier. But when you're stood at the end of the bed looking hard, going, maybe it does fit, but maybe, let's see. But if what, so what? You have to bring this back down into clinical context. So the limitations, I know you know this already, you cannot assess depth. You cannot diagnose behind air. So if there is just a few microns of separation of this parietal and visceral pleura with air, the physics tells you you can't diagnose behind it. You're going to get the same lack of artifact generation from that separation there, whether it's a good few centimeters or millimeters or whatever. So please don't use ultrasound and look down the scale at the side and go, okay, so I can see the ribs, the pleural line, that's about centimeter. My focus is there and I can see 1, 2, 3. Don't do that, okay? Know that there is separation. You can't diagnose, end of story. What you can do is think about the baby's positioning that the baby's nursed in, and mark out, if need be, where these areas change, where you might identify lung point, where it's normal, where it's not. But it can be really, really tricky, guys. Some people will like to look at X-rays and sort of say, yeah, if it's more than 2 centimeters or hits the mid-clavicular line, then it's got to be significant. I don't play with hard and fast rules. I think you have to apply it. Sliding can also be really subtle, and I'm going to show you a few examples here, particularly when it comes to hyperinflation. If you think about it, your lungs are big and bursting and not moving as much. Okay, that can be tricky, and particularly in areas where there's pleural reflection, when it comes around the corner, around the cardiac, or at the end of where the pleural reflections are with the diaphragm. So tiny corners don't move as much as other more central areas. People can also get really confused with the stomach, and that's understandable in our patients when you've got respiratory embarrassment and the diaphragm lifted up. Your stomach and gas-filled bowel can easily come into play, and you can totally get confused here, and I'll show you. So also remember, please, that mirror artifact is not specific. Many of you will use cardiac ultrasound and you'll know almost any strong barrier can act like a strong reflector, and you'll get your mirror artifact, particularly using color when you're looking at the aorta or coming off the capsule of the liver, anything like that. So it's pretty sensitive, but it's not specific for air leak. So this example here, you've got the chest wall, you're in a longitudinal plane. We know that the little ribs are all circles and together. Static pleural line that's not moving, it's bouncing with recession, like I showed you. And it's sort of pulsing away a little bit, maybe, but you've got this sort of mirror artifact. So you'll often see it because that sudden transition is acting like a mirror, but please don't think it's, mirror artifact. It's got to be air leak, because that's not true. I hope this is kind of making sense for everybody and you can hear me and everything. All right, I want you to stare at the screen. Think about this. If I gave you this picture of right posterior longitudinal, so this is a baby nurse prone. So my probe is in a longitudinal plane, notched towards the baby's head always. I've come away from the vertebrae. I'm interested in chest wall, little rib shadows, which are like curves at the moment. You've got your lovely bat signs there with the posterior rib shadows. Your pleural line, it looks really well defined, doesn't it? Pencil thin. I am trying so hard to see, is there horizontal pleural sliding differing from recession? And I can observe here very strong A lines coming down, and I'm struggling to see any B line artifacts. All right, so is this enough to diagnose pneumothorax? No, it's a strong suspicion. You need lung point really here. Okay, so it's very suspicious. And actually just looking at one tiny region, if what, so what? Okay, it's not always really that important. It might just be a slither, a couple of millimeters next to the paravertebral space. What about this one here? This is another patient, right posterior longitudinal, same sort of deal. Again, I'm looking at the tissues, identifying the plane, looking at the pleural line. I wonder if I asked you to vote 50-50, is there air leak here or suspicion? I would say suspicion, but I'm not entirely convinced. When I stare really hard, I think there's really, really subtle movement here. But it could be the twinkling of the slight movement that's going on with recession. But again, go through it. Horizontal sliding, really not sure. I would need B mode, M mode here. I'd really need to go hunting for lung point and really thinking in this area, if what, so what. So it's not crystal clear always. You might stare at the screen for ages, put your M mode graininess. It might just be so subtle and hyperinflated. Okay, so coming on here, this is the region. Here's your M mode. Does that help you?
Yes.
Yeah.
Barcode
It's hard,
scanner.
isn't
Barcode,
it?
yes.
You can stare and stare at these things for hours if you like, but I would say right there, it looks pretty like a stratosphere barcode. You could argue there's a tiny bit of parasite-like movement above the pleural line and below. I think it's pretty suggestive, but it's just difficult. And one of the things to do is just break that cycle right there. What I've done in that patient is gone for the money shot. Where am I most likely to detect pneumothoraces in the least dependent area? If you stop for a moment, come down laterally, okay? Just come down to another area. And if you put your probe on and you get this picture, you can see there, this is a lateral one. You've got your costophrenic angle coming in, little diaphragm, maybe tiny bit of fluid. That's what it should look like everywhere. And if you come back to it and then look at that, that's different. Okay, when it is really hard is when it looks like that everywhere to start with. Okay, can be more in fitting with the hyperinflation and things. So using areas of contrast. So in reality, I would ask you, don't put your probe exactly where you think immediately the air leak is there. Do yourself a favor, 2 seconds, stick it somewhere else, the other side if you have to, and go, yeah, this is what this baby's lungs look like. or the lung artifacts that the pleural surface looks like. Okay, so it can help you a little bit. All right, don't be fooled. Bowel gas can look like air. Easy in the stomach when you have fluid and air present. Some people jump up and down and say, oh my God, look at it. The physics is the same. You've got a visceral organ that's now in contact that will have some degree of sliding because of body movement and everything. But you've got this defined repetition artifact because air at the surface. You might even have the odd B lines as well because there's fluid in there. Okay, so you can get caught out, like I said, when there's respiratory embarrassment, it's coming up high, it's coming up into a zone you don't expect it, or you've got surprise congenital diaphragm, anything like that. But I've seen people report false lung point and getting us horribly down that rabbit hole. It's just because of the region. Could this be stomach getting in the way? All right, a couple of more cases. I hope, is this all going okay for you guys?
Yes.
Yeah, thank you. Okay, lovely. All right, I apologize. This one is a little bit dark. Perhaps it's undergained, but look, this is beautiful transverse superior view. So I love this because you can see the sternum centrally, and you can compare right to left in one shot. Here, centrally, I've got the thymus and cardiac activity all dark beating away here. And I'm comparing the quality and nature of the pleural line from the right superior transverse to the left. And I'm looking hopefully with you that looks defined. It's shuddering away over here. There's some A line presence and there's B line presence. So that's kind of fitting. And over here, it appears again to be a bit of a change. And this is common, isn't it? Sort of parasternal areas. But again, I can't assess depth. I can think about this, that this is probably maybe 0.5 centimeter, a center across before you start hitting this area. So is this significant? You've got to put it in context. All right, and this is the X-ray. Clearly, if what, so what, you've got a rim on that side. You'd have obviously search hard and go, right, I'm interested in that right lower side of it now. You know, minor pneumothoraces, and easy to get excited and jump up and down. Please just don't stick a needle in it immediately. Okay, just assess it, put it in context. It's very likely to go away on itself, or if you know about it and the baby deteriorates, you know the steps forward to go for. Okay, so again, defining when it's next to sort of the sternum, or the same when they're nurse prone and the vertebrae, it can be a slither, and that's fine, but you've got to put it into context. Right, this was a baby that middle of the night kind of stuff, a bit like now. This is a baby born at 28 weeks gestation who had horrible lung disease and just fell apart in the middle of the night with a sudden deterioration. Went on, was actually not self-vented, it was on CPAP, but progressed. The team went up and up and up, put the baby on the high frequency jet ventilator, able to generate really high mean airway pressures. Time I got there, 95% oxygen and things, and we really didn't know what had happened to this baby, but it actually had a catastrophic bowel obstruction and sepsis and thereon. So I'm starting looking, using point of care ultrasound, going, where's the problem? You know, you don't usually blow an pneumothorax at 6 weeks, so just sort of putting it into context. And again, hopefully you can observe that this is an anterior superior transverse tiny baby because the whole chest is in the one plane. So beautiful button sternum in the center. I want you to think about the right side. I want you to think about the left side. But what's going on here? Can anybody help me out? Why aren't we visualizing structures we'd expect to see? We would normally expect to see the thymus and cardiac center right there.
Encroachment of the lung.
Yeah, exactly. First 3 a.m. thinking was, oh my God, is that, no, it can't be air leak, is it? You know, why am I not able to diagnose behind air there? And I think the key is it kind of at first glance can look like air leak, but there's this B-line sort of presence and stuff. And as I take you forward, bringing the probe down the baby's chest sort of to the mid and lower, it starts to become clear. So you've got your right side and movement there. It's the left that's just pushed right the way over. And it's giving you this lumpy, bumpy you know, mixed bag of stuff that you get in cystic BPD, where it's hyperinflated 1 minute and collapsed the next. And it's just literally, as we go forward there, I can show you in the longitudinal plane, if you weren't so clever, you'd realize again that you've got thin define, pleural line, lots of shaking going on, B-line presence, and this sort of mischief. Again, you would normally see thymus structures here and be able to set your 2D power to what it needs to be. Drifting over to the left, I think what we're observing here is the very hyperinflated lung, giving you really, really subtle pleural sliding, defined program, mainly A lines and really occasional intermittent B. So just be aware, this is the cystic BPD hyperinflation, ruining visualization of normal central structures. So clearly, thankfully, you know, ask our team to put the needle down and let's come forward and decompress. And you can see the sort of concerning gaseous distension you've got going on, pushing everything up as well. And this is the sort of appearance as we started to slowly drop that mean airway pressure, starting to decompress a little bit, and in longitudinal plane looking a little happier. Okay, so again, you know, I know there's not a lot of reports out there about the hyperinflation, but I think it does have a role sometimes, and just putting in clinical context in this space. All right, so lung ultrasound is beautiful. It's really helpful, but please have a healthy respect for what it is and isn't. My tips for air leak is really just work systematically and really carefully through your thinking. I think there's massive value in doing sweeps where you're starting centrally in a defined land point, like the sternum and the thymus, or laterally at the costophrenic, and starting and then running medially and observing the changes in the pleural line nature, its movement, and the dominant artifact profile. And that will help you identify lung point. And then once you've done transverse, then please do longitudinal, 2 planes as you would normally with any sort of imaging. As I've said, try not to be tempted to start in the area you think is air leak. First up, do yourself a favor. What should it look like? Why am I staring at this point here for, you know, 45 minutes trying to work out and find lung point? It might just be this is this baby's appearance. Correlate it, all right? It's exciting, but just hold your horses for a moment. Does it make sense? Does it fit with the clinical picture, or is it cystic hyperinflation? Is it the stomach coming in? Is there something else it might recognize? Is it pneumomediastinum? You know, one of the quick ways of looking at that is obviously the lack of visualization of central structures. And just as you do with cardiac imaging, when it's pneumocardiac, you just can't get anything. It's just a mess. It's just no views, and you're not visualizing the heart where you expect it to be. All right. Is there something unexpected here, like stomach and that bowel signature you're observing in the thoracic cavity? All right. And as you know, the limitations of lung ultrasound that you cannot diagnose behind air, you cannot assess depth. All right, so that was an air leak one. I'll pause for a moment. I can see Q&A. Alok, if you can help me out if there's any particular questions about air leak before we talk about effusions.
Yep. So can you hear me, Trish?
Yeah, great. Yeah,
fantastic.
yeah.
So we've got a question from Ahmed Moharram. Ahmed, are you able to unmute yourself? Probably not. So I'll ask the question on his behalf. So what he's asked is,
I can.
Okay, go for it, Ahmed. Yeah.
Hi.
Yours.
Sorry. Hi. Thank you so much for this brilliant talk. Very informative and comprehensive. Just one question. Can we use lung ultrasound to decide either to go conservatively managing the pneumothorax, or that we need to drain this pneumothorax? Or shall we go clinically?
Yeah. I think having a conservative nature in some of them, you have to think, does it matter? You know, and so there's many times I will have a look, you'll have a baby post resuscitation, I have a quick screen of the lungs, maybe a very quick crossover of the heart, is there outflow tract obstruction, you know, things like that, just questions that help you, and a knowledge of perhaps that there is a little air leak, a slither of air leak, but move on. So there's many times I will not intervene, absolutely. as I'm sure you would with x-rays. In our unit, it is protocols to still obtain an x-ray, and that's fine. I think you have to think of your defined clinical question and then compare, and it can help colleagues understand what you're doing, what you're talking about too, and medical legally. But I think, yeah, the serial observation is helpful, and the physics is important. So let's say you have intervened and you have put a chest drain or a needle. The physics is almost instantaneous. So if you've actually drained that air at that point, you will have the parietal and visceral pleura come back together again, and you can see resolution. Okay, it's limited if you have a chest drain in situ and a dressing, you know, tegaderm and all that lot. You can't really use ultrasound in the dressing area, so that might limit your views. But you will certainly see that air leak resolving when you've got parietal and visceral pleural contact again. It can rub away. So I think you can use it really diagnosis. Get a pen if you need to. And I know some of the early studies, I think Capetti and Catarossi, when they talked about if their lung point reached the anterior axillary line in a baby lying supine, you know, it became more important then. It might be. It might have just spread. It might be microns of separation, but it's gone across the chest. And I think you just have to put that and go, okay, is it important in front of my eyes right now? Is the baby compromised? Do we need to do anything about it? Do I just need to know about it? As you would with x-ray. I don't think, you know, you can put it in perfect context of what it means to a 600-gram baby to have lost pleural contact across the anterior chest to a 5-kilo infant of diabetic who's breastfeeding. You know, it's I think it's really just getting that across. It's a helpful tool. Yes, you can diagnose. Yes, you can weigh up, and it adds information, adds clinical information. Serial things, of course, can help you. And I love to show families, if we have intervened or not, that this is the problem. This is what's happened with time. I'm confident letting you go back to the postnate wards now. You've been observed for 8 hours. Nothing's happened. It's looking good. You know, so I think there's certainly, yeah, every day that there's a use for it, whether you get a needle out or not. Does that help you?
Yeah, thank you so much.
So I've got a question from Sophie Reynolds. Sophie, are you able to unmute yourself?
I think so. Can you hear me?
Yeah, we can hear you.
Yes. Hi.
So it's 2 questions, I'm afraid, but I hope I'll try to be quick with them. The first one is, obviously on all the teaching slides, you zoomed in quite a bit on the actual pleural line. When you're scanning in real time, do you keep the depth at like 4 centimeters from preterm, or would you actually zoom in and put the depth about 2 centimeters so you can get a clearer view of the pleural line as you're scanning?
Yeah, that's absolutely right. So remember, everything below the pleural line is artifact. I do it a lot for teaching when I'm trying to demonstrate, say, like coalescent B lines or intermittent B lines. We play with the depth to start with to show you it goes on and on. But yeah, keeping as our sort of the way I've set our machine, a default is around 2.5 centimeters. But I think that's to help you anchor the slide, if you like. So there's always some reference to a physical structure. So like the thymus or the diaphragm coming in. So that helps my laterality. So someone else reading knows that that's a left costophrenic and things. So rather than just looking at the chest wall, you got to annotate. I find that helpful. And I think starting with the focal line just below the pleural line really helps. Setting your 2D grayscale to the tissues. And again, that's where the thymus comes in for me. So you're just getting that nice, comfortable gray, blacky gray, all 50 shades and going on. But then, yeah, sure, zoning on in on that really first 1.5 centimeters, fine. And I guess it depends your question. If it's effusions, obviously, you go for your life. If it's, you know, things lower down. But yeah, I kind of for teaching, try and keep it sort of in a zone out that people can get a bit of reference and context. And I think, you know, I don't know if you found, Sophie, when you suddenly flick to M mode, it can look a little bit clearer whether it's actually the contrast or not is moving. How do you feel?
And that kind of brings me to the other question I had. So when if you find a lung point where you think you might have found a pneumothorax, so you've got your M mode and you've got both some seashore sign and some barcode sign. So I scanned a baby on Friday and we knew that the baby had had a pneumothorax the day before. On our
Mm.
X-ray shortly after this, we couldn't see any air. So was there a small amount of air or not? And you end up with a lung point where you can see barcode and you can see seashore, but actually the pleural line wasn't continuous. So I don't know if that's the baby moving because the baby was upset, or so do you have to have a continuous line, pleural line on your M mode between your seashore and your barcode?
That's interesting. That's not something that I've observed before. I think the
I don't know
pleural
if it's
line
kind of gasping
a little
movement.
difference. Yeah, the
Yeah.
pleural line, when I've seen sort of slight changes in depth, it's usually been related to lung lobes, like a sudden difference between, particularly on the right, where you might have right middle lobe changes and not the right upper. I think really, you know, when you're talking about lung point, you're looking at a really drastic change within one lung region, and it should be really between one intercostal space that you're able to nail it to. It's hard to fully explain what you're observing. It's probably not that significant in that context if it's so tiny and it's flicking in and out. And you're going to find, and remember, nothing's 100%. You know, I think one of the examples I showed you of hyperinflation and the baby lying, could not find air leak for love nor money, but it just looks so much like it. And I couldn't, and I, you know, went back to basics and stuff. And I think you have to go, if it's there, if what, so what? You're putting it in clinical context of a baby who had air leak. There's high chance that there's a tiny bubble of air in there somewhere. Maybe it's trapped in some sort of area, whether in between lobes or something. I guess one other thing you could do is reposition your baby. Think about it and think about whether there's any separation of that pleural space continues with air moving. It's not that reliable, I found. I've done that occasionally when it's come to doing a chest needling and it's not conveniently sat at the second intercostal space mid-clavicular line or anything like that, and you sort of move the baby a bit more laterally, wait 5-10 minutes, come back, and hopefully that air leaks in a nice sort of central area. But I think you just have to go back to clinical context. Sometimes babies do reaccumulate. You're not going to pick it on X-ray, but then you're going to go, if what, so what? I just know about it. I'm going to observe. Is it going to expand in 10 hours, or, you know, am I looking at just a tiny bleb, something that may have been related to the chest drain?
Thank you.
That's okay.
We've got Dr. Ashraf. Dr. Ashraf, would you like to ask your question, please?
Thank you. Thank you for this conservative and informative talk in the target.
No worries.
My question, I am in the pneumothorax. I found some the airline in this pneumothorax. It will be more crowded and condensed than the normal lung pattern. This is true.
So I think, are you talking about how many you would sort of see going from the pleural line down? It's more crowded, that there's lots of them?
Yeah, more in the pneumothorax, the A line more crowded than the normal lung.
Okay, I think what you're looking at is the reflection of tissue structures. So it's probably that your ultrasound is perpendicular to those structures of the tissues within the skin, the fat, the chest wall itself. It's probably a strong signal that you're picking up. I certainly don't count them. I don't, you know, get into that. I think you're looking for pattern recognition of what's mirrored above and below. They certainly appear to be stronger. And you saw one of those examples I showed you. It's like a curvy point of the rib when it was anterior, inferior, and it was almost geometric in its kind of pivotal movement. So I think that the literature would talk about the strength and definition, lack of attenuation with depth, sort of geometric kind of shape to it. I think they're stronger when in the first look you think, oh God, that's quite, you know, prominent. Whether there's more and more of them, I'm uncertain of that, but I think if it is, you have to think why. It's probably because it's acting as such a strong mirror, such a strong reflector. You're getting incredibly strong signals through the tissue it's actually going through, because there's no other, remember, you're not looking at anything, it's just artifact created from that superficial structures. And you're not going to find that You're not going to find the lung line. You can't sort of look at it and go, all right, there's the depth, there's the limit of the visceral.
Okay, thanks. The other question, sometimes there is a small rim in pneumothorax all over the lung. Is this area it will be
Yeah.
found, the images in the imaged most of the area, and no lung buoyant, and the baby not suffering from any clinical symptom?
So not suffering any. So you're talking about a stable baby that you've observed this sort of A prime profile everywhere?
Yeah, yeah. The A-prime profile for all most of area, because this is a small,
Okay.
small rim of pneumothorax around the lung.
It could be. Yeah, I've seen babies that are incredibly stable where I've gone and not been able to find lung point, and it might be that the whole of the lung is separated. But like we say, it could be microns thick, and you have to put it back into clinical context then. You know, you might have bilateral pneumothoraces and even pneumomediastinum if it's been a big recess or something, but it's tiny, so you have to put it back in clinical context. You know, I think, you know, that is certainly when an X-ray would be helpful. Knowledge that, yes, there's been early present. It might look really different in 2 hours' time, or if you're on a ventilator or something. But I think, yeah, it can be a tiny slither in that sort of pneumomediastinal area, or it could be complete, but actually look pathetic on an X-ray. And of course, you're not going to drain that. So I think, yeah, understanding that that minute separation can mean anything.
Thank you.
Okay, no problem.
Yeah.
Would it be okay if we move on to effusions?
Yep, absolutely. Go for it.
Let's see what happens to the screen now. God knows. Hang on, if I can come. All right, I might stop that one. Oh, are we winning?
Yeah, visible.
Can you see that?
Yep, perfect.
Yeah, visible. Excellent. All right. Whew. All right, pleural effusions. This is honestly my favorite thing, so forgive the excitement. This is a little baby I cared for, and I can remember all the ways in lung ultrasound helped us, and the cardiac assessment here. It reminds you how valuable it can be in that it's so well tolerated by patients who are sick as a dog, and you just have to look at them and they desaturate. And so for me, using ultrasound here to assess adequate ET depth, making sure that you haven't got right upper lobe atelectasis, looking at the extent of effusion and collection, efficacy of the drains, whether there's troubleshooting, whether they're dislodged or blocked. And again, sort of looking at diaphragm movement and the actual lung artifacts underneath of how congested these lungs might be or compressed, and the impact. And it was, yeah, this little one was with us for a good 3 months and did brilliantly with the team. So one of the beautiful things here, you will notice immediately that this is a nice sort of costophrenic view. And I've done this just to really show you again with the scale down the side. One of the first things you'll see is just how generous the chest wall edema is in these babies, and that can really guide you from an understanding of the fluid third spacing that you've got going on. It can help you from a proceduralist part when you're thinking about draining, of how deep you might need to go before you start accessing the pleura. But a really sharp contrast here of that tissue wall coming on in, finding your ribs, finding that beautiful pleural fluid, which is that deep anechoic area, and that little lung now floating and suspended in it. So a little bit of a change to terminology. We no longer call it the pleural line because it's not made up of the two in contact. So you might have your parietal fluid or just chest wall, if you're like me, and thinking about things that I would call the lung line. You're going to get some fluid and air artifacts generated within that existing lung, dependent on degree of aeration and interstitial fluid and everything. So again, they throw in new terminology like sub-B lines and that. But I think just coming back to basics, you know, you're looking for that deep anechoic area that's separating the fluid. And for the first time, ultrasound is happy with you because it hates air and it loves fluid, and you can actually start to actually feel something more tangible. It gives you beautiful contrast of organs here. Again, you can see the real difference in echogenicity of standard chest wall edema to that of an encapsulated organ, to movement of the diaphragm and the fluid, and it's crystal clear. You know, one of the things I enjoy least with x-rays of how everything's grey and fluffy, and words are put in to kind of describe areas where you're squinting at thinking, yeah, that's probably the liver. Okay, this is an example I think I've shown before, which is a transverse view. So costophrenic angle, but in a transverse plane. So you're just taking a slice of the chest inside. Always help yourself with annotation here, because you end up head turning and thinking, hang on, so that probe notch, the laterality is pointing towards the bed. So I think I've got the baby lying down. So therefore this is posterior, this is the side, and this is anterior. So that helps you. And I think what I'm observing here is a nice, thick, meaty chest wall in between a rib space for most of it. And I've got this little lung that's suspended in this anechoic fluid. I've probably got fibrin strands and stuff there, probably been there for a while. But more importantly, if what, so what? Look at the lung underneath. Okay, I've probably gone over my marker there. So what can you observe with that lung?
Dynamic
Well
bronchogram.
aerated. Yeah, so it's, I would say it's not well aerated at all. You're observing a picture of hepatization because you've got these sparkly little bits that are bobbing in and out. It could just be bobbing in and out of plain mind, but you've got these areas reflective of fluid and air trapped. And I could not tell you if that's blood. I couldn't tell you if that's Pseudomonas pneumonia. You have just got regions, a massive region of lobar non-aeration or suboptimal aeration. And I think when the one we published, this one, we didn't even drain that fluid. We just changed the mean airway pressure and had a total different recruitability to the lung underneath. So it's helpful in more ways than one. So coming back to our lovely costophrenic angle. So with this, the baby lying supine, you've got your probe that's in the lateral position, notched towards the baby's armpit. And it's nice to see about 3 rib spaces if you can. Beautiful if you increase your depth, Sophie. So if you go down, this time you get to observe really nice movement and definition of the diaphragm moving. And you've got that beautiful little lung bobbing away there, probably a fibrin strand. And it's just helping you appreciate how this baby is breathing despite this fluid. And this is when it comes to measurements, if what, so what, which we'll come to in 2D and M mode, but you're just getting an appreciation of the diaphragm activity and the degree of lung aeration below, and actually then trying to make a clinical decision. Is this something the baby would benefit from draining, and so forth. Okay, coming in laterally. So I think these are quite pretty pictures. So I love the costophrenic angle, sort of wedge-like picture you get, and diaphragm movement. One of my favorites is taking that slice in a transverse plane, and I literally just slide the notch over and annotate it. So here I've got the lateral chest wall. You can see that rib and the surface, beautiful black anechoic fluid, that whole lobe of lung bobbing away beneath me and all sparkly. And just showing a really nice movement coming through. And in my mind and in my notes, more importantly, I start drawing some diagrams then, and it helps people understand the 3D nature of the fluid that's surrounding the lung and suspending the lung, and really can help put in your mind, you know, if what, so what, is it that important right now? Okay, so in that note, you know, many of our babies are nurse prone, aren't they, face down? This is a little one that had Noonan syndrome and recurrent effusions for several weeks. So this is one of the views where the baby's nurse prone. I've got the probe in a transverse plane. You'll see centrally here, this is the suggestion of vertebrae. I should have got it a bit clearer. You would have got nice sort of spinal canal and everything. But just looking to one side, the right posterior transverse. So this is the arc of the chest here, the rib, the chest wall. So this baby's lying down, and I'm looking at the least dependent area now. And what I think you'll observe here is this right upper lobe of lung bobbing away, suspended in rather a lot of fluid. And remember, this is from the chest, from the head down. You're starting to see, even though it's probably coming out at only 0.5 centimetre, it appears that this is significant for this baby. And it was just the start of the assessment. So I find scan in the position that your baby's nursed in is probably more helpful than flicking them over and having a sort of rigid rule about how deep it needs to be. This was significant for a baby nursed supine, that you can only imagine as the fluid, as I take you through, is just surrounding and coming up anteriorly. So all I've done here is slip the probe slightly more laterally. So it's a transverse plane in the axilla this time, not pointing down to the bed. And again, you're observing the whole picture this time, building a 3D example of this lung floating around up in this baby's sort of axilla. So it's coming right the way around that top of that chest wall, side of the chest wall, and over the top. And as I change orientation now, I'm going to come down laterally and give myself an idea of what's happening in the gutters along this lateral side. And I think here what I can observe is a couple of different lobes of the lung, certainly not looking too happy, not well aerated, hepatization, sparkly nature everywhere. I've got my little ribs there, the little fluid, and I'm starting to come. And this is where I might, Humpy, look at depth as well, just to give me a little bit more context of what we're looking at. And again, coming even further, like that costophrenic angle, you'll see that there's at least 2, if not 3 of those sets of that lung that you are able to observe with significant hepatization. And you can see that little diaphragm coming into place. Okay, 2D measurements. Yeah, I think you have to think here what's important, that you're using your anchoring, if you like, from an actual structure. Audrey, come here. You're going from the chest wall medially towards the lung line. Or if you're going from the diaphragm, again, from the midpoint of the diaphragm towards the lung line. And I think you have to say, are you interested in the deepest possible pocket you can find? In adults, that's plab point. But, you know, if what, so what, as the baby breathes in, breathes out, what's the impact? So sometimes I like to take 2 or 3 measurements. So I just get that idea with diaphragm movement, with inspiration at its greatest, what's the impact on the lung? Am I being loud? Sorry. You know, on inspiration, expiration, how much does it really change? You know, clearly you want beautiful images, you want lovely, lots of fluid to measure, but is this a difference for this baby? And so on 2D, chest wall coming in medially, you know, it's not that much at the end of the day, is it? It's just over 1 centimetre, and then coming in inferiorly from the diaphragm into that liver area. So again, using M mode here, movement of structures with time across the line, you get that beautiful wavy sinusoidal breathing of inspiration, expiration. And again, that can give you more accurate numbers. And again, I like to draw pictures in the notes of what it looks like as the baby's nursed, of each hemithorax, draw the diaphragms in, shade, get your coloring pens out of what that big thick rim of fluid is doing, and the impact on the air tissue itself. You might be lucky, I think this isn't a pigtail, this is a decent catheter I managed to get here that's traversing the chest wall and through the intercostal space. Again, you're going to come up with problems all the times, aren't you, with chest drains? Are they kinked? Are they blocked? Are they dislodged? What's happened now? And again, just observing, I've got hepatized lung here. When I'm looking at this really carefully, I think what I can observe here within this lung, can anyone name this sort of sign? I know we've got hepatization, but I'm just looking here, you've got this sort of bobbing nature. There is a term for that.
Red sign, I think.
Say again?
The shred sign.
You've got a shred sign for sure. So you've lost the pleural line, you've got air bronchograms in it. I'm actually getting at lung pulse. What you've got here is the sort of cardiac structures that are really dark, and you just get this beat and bob. It's transmission of cardiac activity. So they're pretty excited about that when it comes to adult medicine, because you shouldn't really see that unless you've got really dense consolidated lung. I think if you go back to old medicine days of like fremitus and all that sort of stuff, you're talking about transmission and conduction and stuff. But anyway, just aside, what I'm observing is like big cardiac activity, a big sort of solid chunk of hepatized lung, with air bronchograms, loss of pleural line, but you're just watching it move as one with the heart. Sorry, that was just a bit of a sideline. Anyway, so catheter coming through. All right, troubleshooting. We all love catheters. So here I've got a left lateral. You can see that with the chest wall rib as it curves right the way around. And I've got this little bit of lung that's hepatized, just like the others. And it's like floating like a sponge to me. It's, you know, clearly not well aerated is how I would put it in the notes. I cannot tell you if that's mucus, pneumonia, bleeding, edema. I can't tell you that. Neither will X-ray, but you can have a look at the extent of compression, if you like, or non-aeration, and you can think about what you can do to change that. But what you might be observing here coming through, if you look really carefully, occasionally this parallel-like structure, that is my chest catheter traversing that space. So essentially it was just blocked, which is common, isn't it? And what I was getting was a big buildup of this fluid, diaphragm down here, and the non-aerated lung bobbing away up here. So clearly I needed to unblock this tube. And I love this for the serial assessments, you know, so quick, so easy, 1 or 2 planes, deepest costophrenic angle, or however your baby's lying. Is it draining beautifully? Is there signs it's blocked? What's the lung looking like underneath? Okay, coming from the side here, same one. So I've got my costophrenic angle. I've really gone to town on the depth here, 5 centimeters here. So you'll observe the chest wall, the little ribs. I've got that massive amount of fluid. You often get little grainy, sparkly bits in it with particulate matter. Again, please don't ask me what's in it. I can't tell you effusions or whatever. When it's complex, you may see more fibrin strands and loculations, fine, but I can't tell you what the content of the fluid is. What I am observing here is this lovely movement here of the diaphragm, aerated structure here, probably stomach, if not, you know, large bowel or something. And again, this little wedge-like of that lower lobe of tissue. Okay, so really being able to show my colleagues at the bedside, yeah, I think this effusion is really significant now, probably to a blocked catheter, but let's look at this baby. We need more breathing support. We need to get this drained probably when you start looking at the amount of fluid accumulating and how it's really coming posteriorly, laterally, and superiorly over the lung. It's got nowhere else to go, you know, it's starting to compress down on it. Again, measuring here, the measurements themselves weren't that exciting. I was just more excited, I think, about the images. But anyway, it's something that, again, you're going to put into clinical context and will it benefit your patient? This is another view. So this is in a transverse plane. So again, this is a slice sideway view of the costophrenic angle. So put that simply, chest wall, crescent shape of fluid. You've got diaphragm coming into play, and this little blob of lung that you can see is so atelectatic now, probably hepatized in the center. It's very hard to differentiate true atelectasis and consolidation. When it's sort of really sucked in, if you like, this probably looks more like atelectasis, smoother sort of contours, less of that shredded appearance. It's more the bronchograms. But regardless, it's just not well aerated to my colleagues, and the diaphragm coming on in there. Okay, and again, if you're going to measure from a structure like the chest wall coming medially and in defined planes, sort of mid of the chest and below. Okay, and this was after, you know, sorting the drain out. You see immediately that there's less fluid. You see immediately that your lung line is now a lot nearer the parietal pleural. It's still not touching immediately, but you're starting to get better artifact generation there and the suggestion of better lung aeration with loss of hepatization. So you've now got more of a defined sort of surface visceral lung line. You're getting B lines present, and I'm a lot happier that this baby's better supported. Okay, so coming on here, so I love my lateral costophrenic views. I'm showing you that. Just forgive me for the sort of orientation. It's the best I could think of. Think of it like looking at a chest CT if you want to, in a coronal plane. But basically, I've got a baby lying down supine. I've put the probe across the baby's chest here. It's in a transverse plane, not a longitudinal plane. So I've got the front of the baby's chest, the back of the bed, and the lateral side. And I think what you're observing here is this deep fluid pocket, which is deep. You've got a lung suspending up here. And this was actually pre and post procedure. So pre-procedure, I'm able to see where my diaphragm is. I'm not going to kebab it as I put the chest catheter through the wall. I know the sort of depth of chest wall I need to penetrate to get to that, and hopefully all should be well. But this was post-imaging. Can I ask someone to interpret this for me, please? So exactly the same plane, and I think we've got a new artifact that you should be observing.
Needle.
Say again.
Needle.
Needle. It can be really quite hard to sometimes visualize the needle and chest catheter going through. Have a guess. So having a look at that chest wall surface.
Can you introduce some air to the space as well?
Yeah, we've kebabbed the lung instead. So what you've got is you are either observing real-time air leak going on, but probably our fault, to be honest. I think it was just enthusiastic insertion. And I think what we've done is pranged the lung, and you'll see these little sort of artifacts bubbling up occasionally, and you're getting A lines. So you've got an example of how you can't diagnose behind air, even with a bucket of fluid behind it, and how it's rising to the surface, helping you with your orientation as well. But you're able to visualize pneumothorax, basically, or whatever the word is for air and fluid in the chest. Yeah, so it's just a complication. So it's something that I used to say, look, you know, we did this sort of semi-blind. We had a look first, X marked the spot, did it. It may have been more helpful to do this as a fully sterile procedure, which I'm interested that others might do if you've got more hands and sterile probe covers and you're very confident with that. But it's one of the problems when you're going through the chest that sometimes you can be enthusiastic and you can nick structures, but that, yeah, is the complication of air leak. Well done. All right, last one here. I said about serial observation. So yeah, this is just my favorite costophrenic angle. You've got a bit of unhappy lung there that's not well aerated, but you're starting to observe these strands of probably fibrin and particulate matter, and you can see better sort of almost adherence to the diaphragm. And this is one that was resolving, and obviously we're going to leave it alone, but it looks like it's all sort of beginning to congeal and get a bit better, but you'll certainly observe that. Okay, so I think lung ultrasound outshines X-rays on every single level when it comes to pleural effusions. I think it can really help you with confirming the diagnosis. It can certainly help you with procedural guidance and your serial assessment of the impact of the fluid and that of your impact and what you observe with your artifacts with the lung, how well aerated or not lung proportions are. My advice, clear annotation. Again, if it helps you, just work midline and work laterally. So starting centrally, wherever you are, front of the chest or back, and then work across the chest surface and then laterally, longitudinal, then transverse, or the other way. It often helps to annotate. You've got your probe marker, which can help you, but believe me, when you come back to look at it 6 months later, you sort of a lot of head turning going on, that's fine. And yeah, just try and sort of put it into context of the way the baby's being nursed all the time. For me, it's often prone, and therefore I've got to assess the baby prone because that's how we're supporting them. But anyway, I think lung ultrasound is brilliant when it comes to this. Limitations, yeah, it's messy. and the dressings of intercostal catheters are impacting your views. Certainly a lot of jelly can get in the way, and it can start to sort of lift off tegaderm and things. So you've got to be really respectful of what's sterile and trying to maintain sort of dressing integrity. But I find it extremely helpful, and obviously really happy for others' opinions too. Okay, over to you, Alok, and questions.
So thank you very much, Patricia, for what was an absolutely amazing talk. I'm going to go to questions. So as a first, I've got a question from Alberto Berenguer. Alberto, are you able to unmute yourself?
Yes, I am. Thank
Go
you.
for it.
Thank you, Dr. Patricia, for a wonderful talk. I
Pleasure.
would like to know, because as the adult world, the measurement of the fluid, the position of the patient has an impact of the estimation of the volume. Does it is the same at the newborn, or it's different? How can we estimate the volume?
I've never really done that. I know there are clever calculations of estimation of volume and 3D structures, and yeah, I'm aware of the work in adult ICU. I don't do that. I will often translate that to colleagues of just how many millimeters I'm observing from the chest wall in inspiration, expiration, and just like the diagram. So I don't actually do any clever maths and actually say the volume is X, Y, Z. Sometimes you'll get that when you're draining it. But I think you have to put it in context. How do we do that in patients? Would you calculate that as mils per kilo? You know, it's interesting. What will the 600-gram baby tolerate on a certain mean airway pressure to another baby that's 4 kilos and self-venting? So I find it really hard, like air, to have any sort of hard and fast rules about that. And I wouldn't. And I think it's the impact on the lung underneath. Like I say, we have a few examples where the fluid, yes, is impacted, but we've maybe been able to overcome that with changes in mean airway or change in strategy and thinking about pathology. It's hard, but I don't, you know, I'm very happy to hear other people's calculations, and that I've always just gone from chest wall inwards and drawn a 3D diagram of what it is from apex, lateral, and diaphragm, and just trying to put that in context. And if I can say to my colleagues, look, it's a good 1.5 centimeters all the way around, coming up superiorly, coming over this is probably significant. You know, I think that's more meaningful than going, oh, it's probably 60 mils. I don't know. I'm very happy for others' thoughts. I've not read anything exciting about that. And, you know, what do you think?
Okay, some authors just multiplied the number by the lateral measurement by 10 or by 20. I don't know if it's really we can be sure about that measurement, or we don't have data.
Yeah, think about the chest shape. I think it's not perfect science, is it? Of not a cylinder and things, but it's hard. I think, like anything, you're just going to have to put it into clinical context, and it's a valuable tool that adds to information from the patient in front of you. And, you know, if you've got a baby heaving and struggling away unsupported or not supported enough, you're going to drain it. You know, the same with air leak. But the serial assessment can help you, I think, when it comes to effusions and, you know, like neonates, non-hydrops, and that when you're caring for them for weeks and weeks and weeks, transitioning on your care, whether it's monogen or whatever you started, octreotide and that. So that serial assessment of fluid production and absorption and that's interesting. But I don't have a good recipe for you for volume calculations, but I don't know if anyone else online has. I'm not sure.
Thank you very much.
I'm going to be honest to say, I don't think there are any studies of the actual formula in neonates. And the risk of extrapolating the adult data is really, it might go against clinical correlation, because clearly that volume of fluid in an extremely preterm baby might actually have much more clinical impact as compared to, you know, a term baby. So I agree. It's very similar kind of an approach to measuring in centimeters from the lateral angle, and really the serial measurement and before and after measurements if we're either tapping or putting a drain in that particular region. Just again, going inferiorly. So very similar approach to what you're doing, Trish. I think one of the important aspects is just making sure that, when you document it, and especially if you're getting somebody else to do those serial measurements, you're just documenting which intercostal space you did your measurements in, so that for continuity, you kind of have that serial follow-up. So
yeah, that's an excellent point. And I think, yeah, when you're scanning, making sure that your area of interest, ideally in principle, is midway through the transducer, if you can, and annotating and having some sort of consecutive way and doing that consistently is important.
There's another question from Surjit. Surjit, are you able to unmute yourself? I think it might be the same question. Yeah.
Yes, sir. It was the same question.
It was the same question. Okay. So there's another question on whether the baby's position, does it interfere with volume estimation, or, I mean, is there a particular position in which you measure it? Do you like the baby supine? Do you like to move from above, below, or?
I think about how our babies are nursed most of the time. I think, like I say, the very sick babies, we do tend to have nursed prone. And if that's how I'm finding them, that's probably more relevant to the baby than to me. What's the impact of it for the 8 hours they're in that position? I think it's more about access to the chest wall, being really gentle, being really mindful that, skin integrity and pressure. And in ultrasound, you don't get better images the harder you press. I think I've seen that before with our team, and get indentations and stuff. So I think put it back into the baby. How is this baby nursed most of the time? You're interested in dependency. Fluid's easy, isn't it? It's going to move around and slosh around a bit. We often find in the left anterior side around the aortic arch, you might find almost pockets of fluid that sort of tend to stay there. They're quite prominent, wedge-shaped and things, and I'm just like, yeah, that's interesting. Sometimes even on the right side more within the middle lobe, and that. So I think there's going to be areas there that the fluid is going to move around less, and that's just anatomy and where it slides in between different lung lobes. But for most simple principles, you're going to find the area of dependency giving you the best weight. But I think for me, when it's coming up, just starting images, I would always usually start in a least dependent lung area, so centrally and coming laterally. And I think you just get a feeling then of if the fluid's creeping up and now surrounding you. And I think that the first image I showed you with the baby prone, there was already a centimeter covering the entire least dependent part. You got to have significant fluid if it's come right the way around the top and done that, and you've been there for some time. So do I have a position? Not always. I just try and make it relevant to the baby. What's the maximum depth in some areas? Costophrenic, clearly, whether you're front or back. It can help you. Sometimes that's when I sort of annotate about anterior axillary line rather than mid or posterior. I think, trying to get it at its deepest pocket. In adults, they call that plumb point, sort of near the tip of the shoulder blade. But I think, you just got to think if what, so what.
Yeah.
And it's not often symmetrical, is it?
No, absolutely.
Or one drains come out days before the other and things. So look, I don't have a favorite. I think you just have to work with the babies and the nurses and, what's comfortable and what's going to give you some information to add to your clinical question and context and where you are today.
I think that was the last question. I'm going to take this opportunity to thank Trish, because you're up really early in the morning for us. God bless you. And thank you so much. I think it's been absolutely
amazing. 1:30. That's not too bad. I know the dogs want to go to bed, but that's...
Thank you so much, and we're extremely grateful. God bless you. And
not at all, Alok. I'm really delighted. Thank you for inviting me. And I think, look, you guys will love meeting Aaron Sett soon. Aaron's my colleague in Melbourne. He's a superstar. He's just finished his PhD and stuff. He's way cleverer than I, but Aaron's fantastic. And I think, look at, congratulations. You put together a phenomenal course. It's really comprehensive. I was excited to see this, and so many speakers around the world. And best of luck with the program.
Thank you so much. And
No
thank you for
worries. Okay.
everybody joining us today. Thank you.
All right, take care. See you.